What's going on, everybody? How are we doing today? Happy Tuesday, fine folks. Hey, Rich Westermeyer here. Today we're going to be diving into a webinar on health plan incentives, but we're going to give it maybe just 60 seconds or so, give everybody a chance to get logged in and get comfortable. This is one you're going to want to take some notes on today. So if you have a pen and paper handy, that will be great. If not, I would say get one ready because you're probably going to have some good takeaways from today. While we're waiting for a few folks to get on and get settled, do we have any F1 fans on the webinar today? I'm curious to know if anybody saw the race over the weekend. Didn't look like it ended too well for Lando Norris in qualifying. He was in 10th place, but made it all the way back up to 4th. But did anybody see that Max Verstappen won again? I don't know about you guys. I'm not a huge Verstappen fan. Getting a little tired of watching him win the race. But while we're waiting for everyone to jump on and get settled in, if you're an F1 fan, drop the name of your favorite racer in the comments. I'm curious to see what kind of folks we have on today. Do we have Team Mercedes, Team Red Bull? Who do we have with us today? So if you're an F1 fan, let us know in the comments who your favorite racer is. Hope everyone had a good Easter as well. We had a phenomenal Easter here in St. Louis. Had to deal with some power outages while I was cooking a ham, so that wasn't fun. But luckily we have a gas stove, so we were able to make it work. All right, we're going to get started here in just a few more seconds. Curious to know if we got any race fans on the call with us, though. Anybody? Any takers on that one? All right, guys. Well, on that note, looks like we have no F1 race fans. Totally get it. It took me a long time to come around on that. I'm big on Team Ferrari. I've been a Ferrari fan for a long time, and now that they have Lewis Hamilton, it's going to be pretty exciting to watch what happens. I think he's still got a lot left in the tank and a lot more to give. But if you're not an F1 fan, hey, Phil, Jackie Stewart, that might be a little before my time, man. I appreciate you jumping on, though, with us today. All right, so guys, I'm Rich Westermeyer, founder of Benesmart, and today we're going to be talking about how you can spot misaligned incentives in your health plan. And since we're talking about health plans today, I'm curious to know what everyone thinks is the biggest threat to your health plan. So if you have an idea or if you have an inkling, drop a note in the comments and let us know, what do you think is the biggest threat to your health plan today? Check this slide out, guys. This is a slide from Forbes, and you can clearly see we have a healthcare problem on our hands. So the U.S. has the most expensive healthcare system by far, close to double of our next closest country, which is Germany. This is the per capita healthcare expenditure in selected countries. And again, this is going back to 2018, but this has not changed. It's likely only gotten worse. So what is it that is costing us so much here with our healthcare system in the U.S.? We're going to try and dive in today and help you guys figure out what might be costing you more than it should be. So what if I told you the biggest threat to your health plan isn't inflation, isn't healthcare costs, isn't claims or compliance? Would you say I'm crazy? What if I told you it was actually the way that the system rewards the people who are managing your health plan? The partners you're relying on could be quietly driving up your costs. Look, I get it. Most health plans today are bleeding money, and it's not because of misuse, but because of misaligned incentives that are built into the system itself. Today, I'm going to show you 3 of the most expensive traps built into today's health plan, hidden incentives that are quietly bleeding your business dry. And more importantly, I'm going to show you what you can do about it. This stuff is fixable, and that's the good news. Most of what we're going to cover today are things you can fix or change before your next renewal. Today's all about seeing what's really driving your costs, understanding the why behind the spend, and building a plan that finally works for your business and not against it. So I did quite a bit of research on this topic before bringing this webinar to you guys today, and I found some interesting articles out there Here's the headline for one: How to Halt the Cycle of Healthcare's Broken Incentives. And this is on Employee Benefit News. So for those of you that are interested in reading the full article, we can gladly send this out over email after the webinar. But I wanted to read you a little bit about what this article says. And this is going down a little bit. It says the power of incentives. Financial incentives drive human behavior. We've seen this throughout history, from tax policies that influence trade in ancient civilizations to modern corporate compensation structures designed to maximize productivity. In healthcare, however, incentives have been perverted and become increasingly misaligned with patients' needs. The system rewards higher costs rather than better outcomes. For example, hospitals and doctors are paid more when they provide more services, not necessarily better care. Fee-for-service reimbursement incentivizes quantity over quality. Insurance carrier profit increases when claims increase. Since most insurers operate on a percentage-based revenue model, higher premiums mean bigger profits. What about pharmacy benefit managers? It says here, pharmacy benefit managers and pharmaceutical companies inflate drug costs, and the opaque rebate system drives up prices, benefiting intermediaries rather than patients. Brokers are often paid more when employer premium rises. Commissions and carrier bonuses incentivize higher costs, which knowingly or unknowingly supports further consolidation in the market. These misaligned incentives explain why costs continue to soar while patient outcomes lag behind other developed nations. And we just saw that on the slide prior. So that's a really good preview to what we're going to talk about today when we talk about the misaligned incentives. But before we do, I just want to call out what's going on in the U.S. healthcare system and why is our spend so much more than other countries. And this is an exhibit from the Commonwealth Fund. It was a really in-depth, well-researched article that shows the components of U.S. healthcare spending where we spend in excess of other countries. And the number one component is the U.S. pays more in administrative costs of insurance. So 15% more of the excess is coming from administrative costs. Providers spend more on administrative activities. That's adding 15% in excess spending. And U.S. pays more for prescription drugs. That's adding in excess of 10% of spending. So those are some of the things that we're going to highlight today. The three main topics that we're focusing on today are broker compensation, network discounts, and the pharmacy supply chain. So this is where we really want to highlight some misaligned incentives and call these out so you guys know what to look for in your health plan so you can be better prepared to have your next renewal conversation. So when it comes to it, starting off with broker compensation, you want to choose your broker partner wisely. So here's a quick side-by-side snapshot, broker A versus broker B, and the criteria in which you may want to evaluate your next broker decision. So broker A charges a percentage of premiums, and with that percentage of premiums, as your cost increases, so does the broker's compensation. Broker A also takes carrier incentives. They receive bonuses for persistency, which means how long they keep the client with the carrier, and volume, by how much of their book of business they put with a certain carrier. Broker A has limited disclosure of earnings, and the incentive alignment, as we hit on earlier, is actually misaligned because the broker's compensation increases as your premiums increase. That is an inverse relationship that's not good for your company. Broker B charges a fixed fee, which remains stable regardless of your premiums. Broker B doesn't take any carrier paid incentives or overrides. Broker B gives full disclosure of all compensation received, and they profit from delivering value and results. So again, choosing your broker partner wisely can have a big impact on your health plan, and we're going to break that down for you in ways that you may not have seen before. So pro tip number one is to cut out commission-driven brokers. This is the first and maybe most overlooked trap. Broker compensation being tied to spending works against you, not for you. So here's a more detailed breakdown of what that compensation trap might look like. So again, we say more premiums equals more income for the broker. So in this example, we see a 4-year pro forma of premiums that gradually increase each year from 2024 to 2027. And we can see along with that a commensurate increase in the broker's compensation. So to break this down, the standard commission model has been around for decades. And this is where a lot of brokers really tie their horse to the standard commission model. When brokers earn more when premiums rise, typically you'll see 3 to 6% as the commission, which is standard on a health plan. And that can vary. It can be as high as 7, 8, 9, 10%. Trust me, we've even seen higher before. But there's no incentive for the broker to reduce costs. And again, this commission can be much higher if nobody's actually looking. So if your plan costs $1 million and your broker's earning 5%, they're making $50,000. Now, if your costs go up to 1.2 million next year, whether that's because of inflation, medical trend, renewal increases, or plan design changes, they're now making 60,000. That's a 20% raise, and it costs you more in premiums. So the question you have to ask yourself is, does your broker get paid more when your plan cost rises? Are they incentivized to bring your costs down? Because if they get paid more when your plan cost rises, your interests are fundamentally misaligned. You'd think that the person managing your health plan and helping you manage your spend would be financially rewarded when they save you money. But in most plans today, brokers are literally paid less if they save you money. So this kind of shows that in the inverse, right? In a standard commission model, if a broker were to find ways to lower your premium, slowly but surely, they make less and less money throughout the course of the relationship with you. So guys, again, we want to incentivize the people that are managing our plan in the right way. So we have to know where to look for the misaligned incentives. And this is just one, the standard commission model. There's some additional broker incentive conflicts that you want to be on the lookout for. So one that we hit on earlier is premium value bonuses, where a broker receives extra payments for maintaining high premium volume across multiple clients. So let's just call out broker A, and let's say broker A has a great relationship with United Healthcare, and they tout that great relationship with United Healthcare and tell you that, they're one of their premier carriers. And let's say the broker A is inclined to place their clients in a United Healthcare plan. What's the reason behind that? Is it because United Healthcare is the biggest and the best in the country, or is it because United Healthcare pays a premium volume bonus and broker A wants to put a significant amount of their block of business with that carrier so they get larger bonuses? That may be okay for you if these bonuses are being disclosed, but you got to realize that at some point that is a misaligned incentive for the carrier to give the broker a premium volume bonus. Next would be a persistency reward. So this may sound familiar to you, it may not, but if you've ever come upon your renewal and maybe you didn't get the best renewal, but your broker was just insistent on you renewing in your current position because there was nothing else out there or nothing better, and it was the devil that we know, there could be a persistency reward behind the scene, meaning that some carriers will incentivize brokers to say, hey, come January 1 of 2026, if 90% of your book of business renews with us, we'll give you an extra $60,000 bonus. So this would be a persistency bonus for renewing clients that are currently in place. So again, it could skew that broker's perception to say, hey, you're in a better place if you renew, or we looked at the market and nothing else seems quite as competitive as this 9-10% renewal that we got. So that could be one of the reasons why you may have experienced that before. And then finally, there's also carrier override. So if a broker places enough business with a carrier, they could get additional payments for placing the most clients with specific carriers, again, limiting your options. So these all create a clear conflict. Translation in English, it's misaligned, right? Guys, it's just straight up misaligned, not in your best interest, not in the client's favor. So these are things that you want to be looking out for. And you definitely want to make sure you avoid the trap of getting stuck on the incentive conflict flywheel. So what that looks like is your premium increases and you're told this is due to the rising cost of healthcare. broker compensation increases because it's commission based, but then there's no incentive to reduce your costs. The broker lacks motivation to lower your expenses. And I want to show you guys kind of a real life example of this. This is from a client that we brought on board a couple of years ago. So the devil we know myth, what is this? Well, there was a manufacturer that we were talking to that had 130 employees, and they stayed with the same carrier on a fully insured plan for years due to their broker's claims that it was the best option. Well, maybe it was the best option out of the options that broker was showing them, but come to find out, the broker was only showing them the same 3 options every year. So you're being shown the same 3 tired options every year. There's a good chance that one option may be the best option. But come to find out, after digging into it, we uncovered hidden compensation. The broker earned not only standard commissions, which gave the broker no incentive to move the client into a better position, but they also earned carrier persistency bonuses. This created a complete lack of transparency. The client had no idea that these financial incentives were driving the broker to continue to recommend the same plan. What we did in this situation is we helped the client do a fee audit, and we found out that their broker on this 130 life case was making close to $90,000 a year. The majority of that in commission, but also some of it coming from the persistency bonuses. This is a really easy one to uncover. I'm going to show you guys today exactly how you can uncover what your broker is being paid and whether or not there's a misaligned incentive in your plan. The fix, however, maybe not as easy. The fix can either be a Band-Aid or probably more like a surgical procedure if you really want to remove this, what I would call a cancer to your plan. So in doing some research, again, I found some great articles. Here's another one that I wanted to share with you, and this is also from Employee Benefit News. Article headline says, changing broker mindset would remove huge obstacles to the healthcare fix. And so let me go ahead and pull this one up. So what it says is, changing the mindset of benefit brokers who are accustomed to all the misaligned incentives of U.S. healthcare is by far the biggest obstacle to fixing a perverse and opaque system that places profits ahead of patients. They being brokers, measure their book of business in dollars or covered lives. It's easy to be tantalized by generous commissions and revenue sharing arrangements with service providers. It's also hard to break with tradition, a reticence driven by fear of the unknown. Those who continue to resist change, however, actually run the risk of losing their employer clients. Corporate HR and benefit professionals increasingly expect transparent pricing, not only on medical services for their employees in group health benefits, but also for the advice that they receive. Again, a really well-written article that calls to light what we just talked about here. So let's go ahead and dive into what that fix looks like. Step 1, if you want to know if you have misaligned incentives, is to conduct a broker compensation audit. Start by asking your broker for full disclosure, commissions, overrides, bonuses, all of it, guys. Really, so the thing is, it's your plan. This is your information. If you don't have this already, the broker should be happy to provide it to you. So you may or may not know about the Consolidated Appropriations Act, also known as the CAA, enacted a few years back. But under the Consolidated Appropriations Act, brokers and consultants are required to disclose direct and indirect compensation when they receive $1,000 or more in connection with your group health plan. So this is a simple ask from your broker, and any broker should provide you with this. Like I said, this is easy to uncover. Now, here's the fix. Once you uncover if you truly do have misaligned incentives in your health plan, step 2 is to align the incentives. And a couple ways you can do that. Number 1 would be, and my biggest suggestion, shift to a flat fee model. So this means that instead of paying your broker a percentage of commission, you agree upon a flat fee, or what we would call a PEPM, per employee per month fee, for consulting on your health insurance. This removes any incentive to put you with one carrier or the other, because the broker's pay is going to be the same no matter what carrier they place you with. So that would be my number 1 suggestion. Number 2, you could look at something a little more creative if you wanted, and this would be a performance-based model where you actually share in success. So maybe you want to tie your broker compensation to measurable results like cost savings in total, or more specifically claims reductions over time. This really gives your broker an incentive to work hard for you and bring down what's driving up your health plan spend, which ultimately is the cost of care. So maybe tying your broker's earnings to a measurable result or a KPI might help your health plan perform a little bit better over the years. You'd probably be surprised. And then last thing you want to do is eliminate conflict. So not only does this kind of misaligned incentive have everything to do with your broker, but it also has everything to do with the carrier that you choose. So remove the vendors that reward brokers for keeping your costs high. And we're going to talk about that here as we move into the next two topics of today's webinar, networks and PBMs. But you want to make sure that all of your incentives across your health plan are aligned. If you can, guys, drop a comment. Let us know if you're currently team flat fee or if you're on a commission arrangement. You may not know this, but if you do, just drop a comment and let us know, hey, I'm team flat fee or I'm on a commission arrangement. All right, so real quick, before we move into the next topic, if you guys are looking for assistance with maybe a broker compensation audit, and you want to do this kind of in the background, we can help you out with this. To get some clarity on hidden incentives in your plan, just DM me on LinkedIn or shoot me an email and DM me the word review. Let's identify where the game's rigged in your plan. No pressure, no pitch, just insight, guys. I'll help you identify misalignments. We can even review your contract terms, and then you can get actionable solutions. You'll walk away with steps that you can take to improve your plan incentives, and I'll also give you our vendor alignment checklist on that call. At BeneSmart, we get paid to make your plan cheaper, not bigger. We don't get kickbacks. We don't take bonuses. And if your plan costs less next year than it does today, we see that as a win, not a problem. But honestly, broker comp is just the beginning of the misaligned incentives. So let's talk about the second way that your plan may be bleeding money. And this is network discounts that actually aren't even discounts at all. So for our second topic, we're going to talk about everybody's favorite networks, the PPO. Those impressive discounts from your carrier may be costing you way more than you think. And it's time to pull back the curtain. So let's look at a real world example here, or obviously what you guys would see or what your employees would see is an EOB. Everybody's probably seen these, many, many times in their life. But every time you see an EOB, the first thing that you're going to see is the amount billed. And that's right here in column G, amount billed in the green. And you can see that for this EOB example from Blue Cross, this was close to an $8,000 claim. Next column, you have discounts and reductions, right? This is the big draw to a PPO. Hey, these services cost $8,000, but with our PPO in-network discount, we're only charging you $3,900. And of that $3,900, you're only responsible for $1,700. This is supposed to feel like a huge win, right? Who wouldn't want a 50% discount? I'd take a 50% discount on my home, on my car. I'd take a 50% discount on my groceries if I can get it. But discount off of what? And that's what we want to look at today. Now, from the employer side, you may have seen one of these reports before. This is a UHC level funded report. And on this, you can see that this client for the time period had 166,000 in submitted claims. And with the network discount, again, they saved close to 50% as well. So $79,000 network discount. And wow, what a huge discount. Close to 50% discount. Member responsibility was only $22,000. This is supposed to make you feel good. But again, we got to ask ourselves, discount off of what, right? So here's an example where we have carrier A who has a 50% discount and carrier B who only has a 25% discount. But when we ask ourselves discount off of what, the billed charges for this procedure were $7,800 for carrier A, and for carrier B, the billed charges were $4,000. So while a 50% in-network discount might sound more appealing, you're still paying more than you would with carrier B, who only has a 25% discount. So I say that to say these in-network PPO discounts, they're really kind of fake math once you break it down and once you understand how they get to these numbers. So let's take a look at that. So first off, It's a hidden markup. It's one of the most deceptive parts of the entire system because it looks like you're saving money. And on paper, like I said, it feels like a win. But here's the truth, guys. You're getting 50% off a price that was inflated by 300% in the first place, right? So if we have a hidden markup of 300% before the discount is applied, and then we get 50% off of the inflated cost, we're still paying too much. Medicare rates often are a third of the discounted price. So that's the true cost. And that really should be our baseline for how we evaluate our health plan claim spend. So let's break this down even further into how network pricing works. So for traditional PPO networks, they negotiate with each hospital, and the hospital negotiates with them based on what's called their charge master prices, okay? So these are inflated charges where hospitals set artificially high list prices. This is the starting point. So, the hospital says for an MRI, we're going to start at $4,000. And the insurance carrier comes in and says, well, if you want our volume of our members, we want to get that MRI for $2,000. Okay, well, the hospital may agree to that, but on the flip side, the hospital will say, okay, on the same side of things, we want $25,000 for knee replacement. And it's a give and take. And the insurance carrier may look at the hospital and say, okay, we'll give you $25,000 for the knee replacement if you give us $2,000 for the MRI. So the network negotiation is where the PPOs negotiate large percentage discounts from already inflated prices. And then you get impressive reports. Your statement showcases 40 to 60% savings, and these look substantial. But in reality, you're still paying 2 to 3 times more than Medicare rates for the same services. You heard me say that twice, Medicare rates. We're going to be unpacking that here in just a second as well, so stay tuned. So here's another interesting article that I found on Benefits Pro. Headline of the article says the truth behind network discounts. And this is from this article was just published 2 weeks ago, May 15th, or just a week ago, May 15th. I'm sorry, this was published last year, 2024. So it starts off saying, obviously, you can read it there on the screen. A big part of the solution is for employers to advocate for themselves and probe for deeper information when comparing plans. But it goes on to say, the truth is that discounts don't tell the whole story. First, administrators do not agree on a definition of network discounts. So how they get to their discount is different from administrator to administrator. So somebody may be touting a 50% discount, but again, while another company is touting a 60% discount, they may not be touting that discount off of the same cost. So you never know how they actually arrived at that number. Sometimes a discount is what you'd expect, a discount off billed charges that participating providers will award your employees. But often there's much more going on behind the scenes to arrive at the marketed network discount. The truth is, a higher discount often costs more for employers and the entire healthcare system. And so I thought that this right here, what I'm about to share with you, is a very dirty little secret that has to be called out. Discounts often include claim denials and claim editing. So many administrators overstate their discounts by including claim denials and aggressive claim editing practices. While these practices serve a legitimate purpose to catch errors and prevent waste and abuse when used appropriately, if a carrier is too quick to deny claims, which we know they are, or is overly aggressive in claim editing, healthcare costs increase because the provider will likely file an appeal, which will be overturned, which costs more administrative money, which we saw earlier. In the meantime, the same administrator that denied the claim, they will claim a 100% discount for that denied claim. This is an egregious practice by administrators that can cut into legitimate and necessary treatment, resulting in a terrible experience for your employees, an administrative headache for the human resources team. So, if they deny a claim, they're going to mark that down as a 100% discount and apply that to your perceived discounts. And I say perceived. Pretty shady practice in my book. So how would you know if you're actually getting a good deal, right? This is important. When we're talking about this, we don't want to just point out the problem. We want to talk about the solution. So how do you know if you're actually getting a good deal? Well, the thing is, you need standardized pricing in order to know if you're getting a good deal. Unfortunately, our market has a very hard time with sharing pricing, with being transparent about pricing, with publishing pricing. So here's a tool that we use internally, but I just wanted to share with you guys what this looks like. So this is a surgical procedure to replace a knee joint here in my hometown. And you can see the average market price for a knee joint replacement is $14,200. But you can see that the lowest insured price is $3,700 and the highest insured price is $23,000. So I don't know about you guys, but I'd rather have the health plan that's paying $4,000 for the knee replacement than the health plan that's paying $24,000 for the knee replacement. So again, how do we know if we're getting a good deal if all we have to look at is what the network deems as our discount? So this is where you can really have an impact on the cost of care within your plan, and it's using a standardized rate. And what that standardized rate is in our industry, it's Medicare. So let's talk about how Medicare becomes a standardized rate for the cost of care. Well, first and foremost, it's because Medicare, federal government, is the single largest provider of healthcare in our country. Over a third of people in our country receive their health insurance through the federal government by way of Medicare or Medicaid. And I think it's actually a little higher than that. It might be close to 40%. So because they're such a large procurer of health care for the people on Medicare or Medicaid, they have a lot of bargaining power. So they can go in and say, hey, no, Mr. Hospital, we're not going to pay $2,000 for an MRI. We know the cost of that MRI is $250 for you and your staff. We will give you $450 for that MRI so you can have some profit in there. So they set a fair and reasonable price, and this is the CMS, Centers for Medicare. They set a fair and reasonable price for what Medicare is going to pay for that procedure. Now, I'm not saying that commercial employers, commercial health plans should be paying Medicare prices, right? That's not what I'm saying at all. I'm saying you should use that price point as a reference. So here's a quick example of what that might look like in the knee replacement situation. So let's say the hospital's artificially high inflated charge is $75,000. So that's the hospital bill charge. But your great PPO offers a 50% discount. So your PPO price is $37,500. Well, Medicare would have paid $15,893 for that procedure. You still overpaid by by more than double on that procedure. So again, looking at Medicare as a reference price is going to be great for helping you know whether or not you're getting a good deal. And this is to avoid the illusion of savings. Look, said simply, it's like buying a suit that's marked up to $500 and feeling good because you got it on sale for half off. But maybe the suit's true value was only $100. So you have that artificial markup, perceived discount. You get the warm and fuzzy feelings. But at the end of the day, we need a reality check, and that reality check becomes standardized pricing. The whole parallel to this is that our health plans work the same way. So here's another real world example. A construction company with 90 employees overpaid by $7,800 on just one procedure that we saw. Imagine this across all claims for 90 people. Hospital bills $27,000 for an outpatient procedure. 60% discount brings the cost down to $10.8K. And that's what your health plan paid, is $10.8K. But the Medicare rate for that outpatient procedure is only $1,500. Your health plan overpaid by 8 or 9 times on that procedure. The same procedure could be paid for maybe at 200% of Medicare, bringing the cost to $3,000. This is a fair and reasonable market rate that many providers would be happy to provide the service for. So what's the move? Well, here it is. Step 1 is to understand your costs. So stop focusing on discounts, start focusing on reference points. Medicare is a great starting place. It's publicly available. It gives you a baseline for what services should actually cost. So when you use Medicare as a baseline, ignore your discount percentages. You can then begin to figure out how much you're overpaying. And when you really understand how much you're overpaying, once you see this, you really can't unsee it. You're going to want to find a way to fix it. Now, step 2, in order to fix this, you have a couple options. So one might be to provide price transparency tools, help employees make help employees make smarter choices by having access to real data that can help them make the best decision to keep their costs low. Or maybe another great solution, and one that we're a big proponent of, would be directly contracting. You may not know it, but there's probably health systems in your backyard that would gladly open the door to negotiations with you and offer you a direct contract to pay a fair and reasonable price. If you were to say, hey, we want to send all of our employees to your facilities, what kind of deal can we work out? And then a third and really aggressive option, I would say, is reference-based pricing. So that's just to eliminate networks altogether, pay based on Medicare rates plus margin after the care is delivered. So you have a couple different options when you want to evaluate network pricing solutions. And trust me, guys, you want to evaluate network pricing solutions. Here's just an example of the same knee replacement that we looked at in my neck of the woods, which was averaging, I think, $14,000, averages $30,000 in the city of New York. And in the city of New York, we can see if you go a little outside of New York, you can end up paying $71,000 for that knee replacement, $89,000 for that knee replacement. If we look over here in this top right corner, right below Port Washington, we can see $89,000 for a knee joint replacement or $23,000. Both of these hospitals were rated 5 stars by CMS, meaning they deliver excellent care. One charges close to $90,000, one charges close to $23,000. When you have PPO networks, you're giving your employees freedom to choose, which is great, but you're not really giving them any of the tools to make wise decisions, which is where price transparency tools can become really helpful. So I know I've shared a lot. Take a deep breath and then take a look. Let me help you discover misaligned incentives in your current health plan with our free health plan review. If you're interested, guys, DM me a review. We could take your existing data and help you benchmark this against Medicare so you can get a true idea of whether or not you really are overpaying. And that's something we'd love to help you do. And again, you can walk away with some actionable solutions after that health plan review. All right, so with our third topic, we're going to talk about the pharmacy supply chain. And this is a big one. This is a real hot button topic. And we also like to call this in our industry some really low hanging fruit. You know what I mean by low hanging fruit? That first apple, it's easy to grab. You can pick it off the tree. You can access it without a ladder, and you can make this change pretty easily in your health plan. But the pharmacy supply chain may be the most egregious health plan incentive problem, and it's hiding in plain sight. So if you aren't familiar with your pharmacy benefit manager or how they operate, I'm going to tell you need to get familiar with it. Here's a quick look at the pharmacy benefit supply chain, and you can see at the center of it in red is the pharmacy benefit manager. But look at all the stops along the way, from the drug maker to the wholesaler to the pharmacy to the consumer, right? There's a lot of different stops along the way, and everybody takes a little piece of the pie in this supply chain. Most plans today are unknowingly subsidizing this supply chain, and it's hidden right in front of our eyes. So how do PBMs get paid? Well, they get paid in a number of different ways, and here's 5 of them on the screen. But for today's call, we're just going to focus on rebate sharing and pharmacy spread. We think these are probably the 2 most important that you can impact right away. And while we're on the topic of PBM-owned pharmacies, I don't know if anybody saw it, but I think it was just last week or the week before, and I could get the state wrong, but I want to say it was Arkansas. It was an A state. It was either Arkansas or Alabama that came out with a bill saying that they're not going to allow PBMs that own pharmacies to operate in their state anymore because it is too misaligned and it is costing employers and employees way too much money. So let's start by looking at some of these ways that pharmacy benefit managers get paid, because they're the middlemen. And I believe they often engage in questionable practices that increase the costs for patients and employers. So first things first, we have the spread pricing model. What does this mean? Well, spread pricing is pretty simple. They charge $10, they keep $5, and then they pay $5 to the pharmacy that dispensed the medication, right? So they're taking a spread right off the top. They charge your health plan $10 for the drug, they keep $5 in their own pocket, and then they give 5 to the company that actually gave the drug to your employees. So the opposite of a spread pricing model would be a pass-through pricing model. It's where they charge 7, they don't take a fee, and they give $7 to the pharmacy. So very important to know the difference between the two. Another thing that I want to point out while we're talking about PBMs and pharmacies is you want to have a solution for specialty medications in your health plan. Right now, the incentives that are on specialty medications for PBMs are so misaligned, and it's costing employers and employees alike millions and millions and millions, if not billions of dollars a year. So specialty drugs, there's been an 84% increase in specialty drug rebates over a 2-year period. 84% increase. That's significant. At the same time that there's been an 84% increase in specialty drug rebates, there's been a 56% increase for total spending for specialty drugs. It's like, as my grandma would say, no shit, Sherlock, right? 84% increase on drug rebates, 56% increase on total spending. Makes total sense that it's the rebates that are a huge part of the problem. Same thing on brand drugs, 125% increase in rebates on those drugs, 90% increase in total spending. And the fact of the matter is that while specialty drugs only account for about 1% of drug or PBM volume, they account for 44% of your spend. So if they're accounting for close to half of your PBM spend or your RX spend, then you really want to put a solution in place for this. And here's another dirty little secret that I want to point out that you may or may not have heard of before, but a GPO. What is a GPO? Has anybody ever heard of that? A GPO is a group purchasing organization, and the group purchasing organization acts as a rebate aggregator. So you can see here on the screen, Ascent being one of the bigger GPOs. Ascent is a rebate aggregator between multiple commercial health plans. So what they've done is they've formed an entity which is actually headquartered in Switzerland. So if that doesn't tell you something's wrong right off the bat, it should. They formed an entity headquartered in Switzerland for the sole purpose of aggregating their buying power to get better deals on rebates for the drugs which your company pays for. This is fundamentally misaligned. So if we break it down, what are these GPOs doing? Well, you have Ascent, which we just mentioned. They combine the purchasing power of Cigna, Express Scripts, and then you have Prime Therapeutics, which is lumped in there from Blue Cross Blue Shield. And then you have UHG and Emisar, which is also combined with Elevance. And then you have Zinc, which is CVS and CVS Aetna. So you have 3 main PBM-led GPOs on the market. And Phil, I hear you, spread pricing is a huge problem, and PBMs are going to start touting how much they retain in rebates. Well, they siphon off way more money with the spread, right? So just because you're getting rebates doesn't mean that your problem is solved. And so here's the pharmacy benefit manager trap, which you want to avoid. You want to avoid spread pricing, you want to avoid rebate retention, and you definitely want to avoid formulary manipulation. And here's another one, contract complexity really obscures the true costs. If you're interested in learning more about the PBM trap, I can tell you that on next month's webinar, we have a bona fide PBM contract expert stepping in to talk to us about how we can actually read these contracts and make them make sense. So here's the reality, guys. If the markup on prescription drugs is not looked at, it's going to be a runaway cost for you. So if your plan is charged $200 for a drug, the wholesale cost of that drug may only be $20. This is a 900% markup. Do you think you can really manage your costs when you have 900% markups hidden inside of your plan on an everyday basis? The rebate game is pretty simple. The manufacturer who makes the drug offers the rebates to the PBM to place the drug in a certain spot on their formulary. You're left guessing. You have limited visibility into the actual rebate, the amount or the percentage. All it does is result in higher costs for you. So the problem often lies in the fine print. PBM contracts are like a black box, guys. I mean, legal jargon which you couldn't ever imagine, vague, hard to define terms, and really structured to avoid audits unless you have lawyers on standby. Here's a funny one. I asked ChatGPT, what grade level do I need to read at to understand PBM contracts? And ChatGPT told me to understand PBM contracts, you need to read at a graduate school level, think grade 16 plus. But that's not because the information is actually that complex. It's because the contracts are intentionally written in dense, legalese heavy language designed to obscure meaning and avoid scrutiny. Guys, if ChatGPT knows it, we need to be digging into it. So here's a real world example from a client of ours. A mid-sized manufacturer needed a specialty medication. Their carrier claimed the drug cost $4,500, and they boasted about saving 30% through their PBM network. The plan still paid $3,100 after the discount. We found out the true cost of the medication through an independent pass-through PBM was $612. Same drug, same dose, same manufacturer. That's $2,500 in pure markup, 515% premium paid to a middleman. Guys, this is hiding in plain sight, and I want you to know how to fix it. So step one, audit your PBM. So how do you audit your PBM? Well, don't settle for one of their PBM produced glossy PDF reports. Get a full file of all of your claims that were run through your health plan, name, cost, dosage, and if they can't explain it or they don't want to share it, then they shouldn't be managing your pharmacy spend. So that's step one, is to audit your PBM. Step two would be to carve out your PBM. Again, I said earlier that this part can be considered low-hanging fruit. You can easily change out your PBMs at your next renewal. Carve out your specialty pharmacy, seek an independent pharmacy benefit manager, utilize transparent pharmacy benefit managers, and start comparing real costs of drugs. Lastly, demand transparency. Demand transparent contracts, require full auditing rights, eliminate spread pricing from your PBM arrangement, and opt to retain all rebates. It's a very simple question to ask your PBM how they get paid. And if they're not willing to help you understand how they get paid, they're not working in your best industry. So pharmacy cost solutions, transparent PBMs, regular audits, and carve-out programs for specialty and maintenance drugs. All right, guys. Well, I want to bring this home again with the biggest threat to your health plan. It's not inflation, it's not claims or compliance. It's more than likely the people that you're paying to manage it. You have your broker compensation driving up your costs, hidden in plain sight. You have network discounts giving you an illusion of savings. And finally, you have your pharmacy supply chain where your PBM acts as a middleman and profits from hidden fees. They're less than a middleman, and they're more like a margin manager. So guys, it's time to flip the script. We're talking about some serious savings on the line here. If you can do a broker compensation alignment, your savings potential can be anywhere from 1% to 5%. So moving from commission-based to flat or performance-based fee removes incentives and gives your broker an opportunity to truly work for you. If you carve out your PBM, your savings potential is anywhere from 10 to 20% on your pharmacy spend. And then lastly, if you look to directly contract with a hospital or a health system, your savings potential is even greater, from 10 to 25% on your inpatient or outpatient spend. Guys, we're talking about significant savings. So I encourage you to take action before your next renewal. If you're interested, book a health plan review with us. It'll be a free 30-minute consultation where we can help you call to light some of these misaligned incentives. We'll even give you an alignment scorecard so you can share this with your team. This alignment scorecard is going to be free for anybody that books a health plan review this week. And you can start saving by your next renewal. You don't have to wait until you get your renewal. Leave those reactive strategies in the past. Move to a proactive strategy so you have a plan in place to save anywhere from 20 to 40% by your next renewal. That's all I got for you guys today. Really appreciate your time. I want to give you just a couple minutes. If you have some questions, go ahead and drop those questions in the comments for us. I'd be happy to stay on for a few minutes and answer any of those questions. All right, I don't see that we have any questions coming in, so I'm just going to wait maybe just another minute to wrap up. If anybody's still typing away, if you have any questions, go ahead and just drop them in the chat. But again, guys, whether you joined us on LinkedIn today or whether you joined us on YouTube, we appreciate you being here. Hope you got something valuable that you can take away and implement for your next renewal. Brett, appreciate your comment. Thanks for being on with us.